Lauren Ruotolo, who is the Vice President of the Fibrous Dysplasia Foundation, one of our loudest voices and strongest advocates.
Literally and figuratively.
Yes.
The smallest, but the loudest.
Dr. Gomez-Lobo, who is a board-certified obstetric and gynecology physician. She provides gynecologic care for pediatric patients, and she is one of the country's experts on disorders related to sexual identity. Dr. Alison Boyce is one of our heroes, who is a pediatric endocrinologist at the NIH. She consults on everything and everything. And Dr. Michael Collins, who is the chief of skeletal disorders and mineral homeostasis in the cranial, facial, and skeletal disease unit of the NIH. He's an active member as well as Dr. Boyce of the Fibrous Dysplasia Foundation, and are really the driving forces in the world for change for McCune-Albright syndrome and fibrous dysplasia. So we owe utmost respect to them. So thank you for being here.
Hi, thank you. Thank you. So this is my last talk, so I hope you guys aren't totally sick of me yet. So I'm going to be going through the endocrine features of FDMAS, and I'm going to focus this more on the pediatric side because that's my background. And Dr. Collins is going to speak specifically to some of the more adult issues. So I know, as we've heard today, FDMAS is a very complex bone and endocrine disorder. We've heard over and over how no two patients look alike. And part of the reason for that diversity in presentation really is the endocrine disease. Endocrinopathies can lead to very, very different presentations in different patients. They can lead to dramatic presentations in different patients. So sorting out the endocrine component, what's involved and what isn't involved in each individual patient, is a really, really important part of taking care of them. So I think you saw this slide earlier in Dr. Collins' background presentation. I think it's a really important slide, which is why I included it. So we know that the mutation that causes McCune-Albright syndrome happens very, very early while patients are still in utero and the babies are still forming. And at the time of birth, if we had a special scan that could show us everywhere the mutation was present and every bit of tissue that's going to be effective, that would be fabulous because the mutation is there that early. But the actual clinical presentation of the mutation, so the problems that the mutations lead to, don't show up right away. Really, the only feature that is present right at birth are the cafe au lait macules. The fibrous dysplasia we know comes up over the first few years of life, and the endocrine problems as well often show up within the first few years of life and later as kids are growing and developing. So this slide really shows, when the diseases can be subclinical, so they're silently present, and when they are clinically evident. And one of the main take-home points from this slide is that it's very, very important when you have a child to do a staging evaluation to look head to toe to see what tissues are involved and what tissues aren't. And if you have a very young child, you need to repeat that until they get to an age where we would expect all of these problems to be present. So one of the earlier problems that tend to show up, particularly in little girls, is precocious puberty. So in McCune-Albright syndrome, precocious puberty is very unique. It does not present the same way precocious puberty does in other conditions. So McCune-Albright syndrome precocious puberty in girls is very specifically due to cysts in the ovaries. The ovaries form these cysts, and the cysts spit out very high levels of estrogen, levels that you would expect to see in an adult patient. They can come on very suddenly, and then they can go away just as suddenly as they come. So what you'll typically see is a little girl cyst will develop, and a little girl will all of a sudden start developing breast tissue. They'll start growing quickly, and as the cyst goes away, the estrogen levels will drop very quickly. And that's that quick drop in estrogen level that signals vaginal bleeding. And vaginal bleeding is usually what people notice first, and that's when they bring their child to the doctor. What can make this very tricky is by the time the patients have the vaginal bleeding, often the cyst is gone. And if you do labs, the estrogen levels aren't high anymore. So it can be really hard to figure out what's going on until another cyst presents. And some patients will have very frequent cysts. They'll have cysts every month. Some will go 6 months or even years in between cysts. So it can be very difficult to figure out what's going on. So the reason we care about precocious puberty in MAS is for two reasons. So there are of course there are psychosocial consequences of having early maturation. It's not good for kids to mature early. It has effects on their brain. It has effects on their function. But also, what's very important is that if estrogen levels are not controlled in little girls, they will grow very quickly, and they may appear to be the tallest girl in their class. But what's also happening is their bones are maturing very rapidly. So they'll actually they'll stop growing early, and will end up quite short in adulthood. So we need treatment for two reasons: to protect the adult height, and to prevent these psychosocial consequences. And Dr. Gomez-Lobo may speak a bit more about this, but one important point that we try to spread to patients is that you really want to avoid doing surgery on the ovaries in girls with MAS unless you absolutely have to. So it's quite common if a girl presents to the doctor with a lesion in her ovary that's causing these hormone problems, it's a natural response to want to go in and take that lesion out. So we've seen lots of patients where they've either had cystectomies, so doctors have gone in and removed part of their ovary to take that cyst out, or taken out the entire ovary itself. And it's just not an appropriate treatment in McCune-Albright syndrome because we know the mutation is still there in the ovary. The cysts are going to come back. So performing surgery is not an ultimate fix for this problem. So we really want to avoid it unless we absolutely have to. So we have very good treatments for precocious puberty in girls. There are two main ones that you'll see most commonly used clinically. One is tamoxifen, and this is a drug that acts at the estrogen receptor. So it prevents, in the bones and in the breast tissue, it prevents the activity of estrogen on its receptor. So although you may have very high estrogen levels, the estrogen is unable to cause problems like breast development and rapid growth. This has been studied in one 12-month clinical prospective trial. That means they treated girls and then they watched over time what happened to them in 25 girls, and it was very effective. We saw a decrease in their growth acceleration. We saw less maturation of their bones and less vaginal bleeding. One thing that was a concern on this study, however, is the actual volume of the girls' uteruses increased over time on this medication. And that makes sense because one thing tamoxifen does, although it blocks the activity of estrogen in the breast and the bones, it actually increases activity of estrogen in the uterus. So personally, I find it a bit concerning to treat a little girl for years with a drug that's going to increase her uterine growth. So that's just something to consider with this medication. The other major medication that's used is letrozole. This was a drug that was actually studied at the NIH, and this is what's called an aromatase inhibitor. So it's a drug that blocks the conversion of testosterone to estrogen, so you're unable to form the estrogen. This was studied in a 36-month trial in 9 girls with MAS, so smaller numbers than the tamoxifen study. And it was very effective as well at decreasing the growth acceleration, decreasing the maturation of the bones, and the vaginal bleeding. We did see one case of ovarian torsion in this study, and that is a complication where the ovary kind of twists around itself, and it can be quite serious. It can lead to necrosis of the ovary, and the ovary can be lost. However, our feeling at the time the study was done is that that's a complication that can happen sometimes when patients get cysts. We've seen a few rare cases in MAS, and we didn't think it was likely due to the letrozole treatment. And indeed, we've followed up now, since have a lot of follow-up data on our patients treated with letrozole, and have not seen any additional cases of ovarian torsion. We now have, this is a recently published paper on 22 patients with a mean treatment period of 4 years. However, some patients were treated quite extensively, greater than 10 years, and it was very effective in decreasing the bone age advancement and controlling the symptoms. So our personal preference is to use letrozole as the first-line treatment. We think it's safe and effective. And then we add additional medications such as tamoxifen if letrozole itself is unable to control the puberty. So as we know that MAS quite frequently affects the ovaries, and about 85% of our patients have presented with precocious puberty. And MAS is just as likely to affect the testicles. We see lesions in the testicles in about 80 to 85% of boys and men. However, this is much less likely to cause precocious puberty. So precocious puberty only occurs in about 15% of boys with McCune-Albright syndrome. And the reason for that we don't entirely understand, but Again, there are effective treatments for boys with precocious puberty. We use spironolactone, which is a drug that blocks the testosterone receptor. And then we use letrozole in combination to prevent the bones from maturing too rapidly. Again, we really urge our patients to avoid surgery if not entirely necessary. So these are pictures from testicular ultrasounds. And you can see the lesion on the image on the left shows these really rough kind of masses in the testes, and the one on the right shows some calcifications. If a doctor sees these images and they're not used to seeing McCune-Albright syndrome, or they're not knowledgeable about what kind of complications you can have in McCune-Albright syndrome, this could very easily be called testicular cancer. And we know that these lesions are benign. They're not malignant, and they do not need to be removed. So that's just part of educating and advocating for yourself or for your child, is being aware that these features are there and how to manage them. There have been a few very rare cases of testicular cancer in McCune-Albright syndrome. We think, therefore, that there probably is a very small increased risk of malignancy in these lesions. However, it's very uncommon, and we just recommend that patients have, if they do have these type of testicular lesions, have them monitored with clinical exam and periodically with ultrasound. But in all likelihood, they're very unlikely to cause any complications. Thyroid disease is probably the next most common endocrine feature in McCune-Albright syndrome. At the NIH, we see abnormalities on ultrasound of the thyroid in about 2/3 of our patients, and we see true hyperthyroidism in about 1/3 of our patients. And so these are typical findings that patients will present with. So this little girl has an enlargement on her neck, on her thyroid. That's called a goiter. It's because her thyroid has kind of grown large because of the McCune-Albright mutations. And then these are characteristic ultrasounds. You can appreciate those like black Swiss cheese type of holes. That's a very typical finding if you do an ultrasound of the thyroid in a patient with McCune-Albright syndrome. The hyperthyroidism in McCune-Albright syndrome is a little unusual compared to typical hyperthyroidism and other disorders. This is an overproduction of T3, which is one type of thyroid hormone. In Graves' disease, a more common type of autoimmune hyperthyroidism, the overproduction is in T4. And that's an important point for clinicians to recognize, because rarely you can miss hyperthyroidism in McCune-Albright syndrome if you don't know to measure T3 specifically. Another point I want to make is that, even if a patient has an abnormal ultrasound and normal thyroid function tests, they do need to be followed over time, because we have seen, in particular in children, hyperthyroidism develop later, as late as age 10 to 12. Management of hyperthyroidism in the short term includes medications. The one most commonly used is methimazole. This is a really commonly used medication. It's a very well established medication. It's quite safe for short-term use. In general, though, methimazole does carry possible risks of toxicity in the liver or toxicity in the blood, so we try not to use this medication for a very prolonged period of time. Most people try to limit use to about 5 years or so. So most patients with McCune-Albright syndrome will eventually go for long-term treatment of their hyperthyroidism, or permanent treatment. There are two methods of doing that. So you can have surgery where the thyroid gland itself is removed, or you can have radioactive iodine, where a little bit of radioactivity is injected into a vein, and it is taken up by the thyroid gland, and it destroys the thyroid gland. Both of these cases will result in long-term hypothyroidism. So instead of having an overactive thyroid gland, you now have an underactive thyroid gland. And patients will need to take thyroid hormone replacement for life. Thyroid hormone replacement is a really easy medication, though. It's far easier than methimazole. It's extremely safe. It's essentially the same thing as the body would be making on its own. It's very easy to manage. So we definitely consider that a preferable long-term condition compared to hyperthyroidism. In general, we tend to perform surgery for our patients, but one very important point to remember is that outcomes from thyroid surgery are much, much better when they're performed at high volume centers. So the number of thyroidectomies that a surgeon is performing per year is a very important figure that will determine how well their patients do. So it's really, really important to select the right center. Also, we have rarely seen thyroid tissue regrow after surgery. Usually it takes quite a long period of time, over years, but it is important to continue to monitor patients for recurrence of hyperthyroidism, and we also monitor with ultrasounds to monitor for regrowth there. There have been a few cases of thyroid cancer reported in McCune-Albright syndrome, but again, this seems to be a relatively rare complication. So similar to the MAS testicular disease, we think there probably is a very small increase for malignant potential, but it's something that's unlikely and can be managed just with monitoring. Growth hormone excess is a less common endocrine complication. However, this is a really important one. We see it in about 15% of patients in the cohort at NIH. So most clinicians will think about growth hormone excess when they see a kid who's growing quickly. So growth is usually their most important indicator. But this is really complicated in McCune-Albright syndrome because there's a lot of things that can make these kids grow quickly. Precocious puberty can make you grow quickly. Hyperthyroidism can make you grow quickly. Hypothyroidism can slow your growth. So using growth as your benchmark for the diagnosis of growth hormone excess, I think, is not sensitive enough in these kids. We have seen a number of patients, like the one you might see here, that have two endocrinopathies that almost cancel each other out when it comes to growth. So a patient may be short from uncontrolled precocious puberty, but tall from growth hormone excess, and those two things have led them to have a completely normal growth curve and a normal height. So it's very complicated. So as we heard in one of the previous lectures, one of the most important reasons to identify and treat growth hormone excess is it really exacerbates craniofacial fibrous dysplasia. This is one of the few factors we know can drive expansion of fibrous dysplasia. And the issue that really brought this to the forefront and led us to recognize this were the effects of growth hormone excess on vision loss. When some of the early work that Dr. Lee described showed that that one of the earliest observations from the natural history study was that prophylactic optic nerve decompression led to increased risk for vision loss. However, out of that cohort, the observation was made that of the patients who had vision loss, they were much more likely to have growth hormone excess. So that seemed to be one of the major risk factors for developing vision loss. We were then able to extend those studies to show that if you diagnose growth hormone excess early, during childhood, and you are very aggressive about appropriately treating the growth hormone excess, we seem to be able to manage this risk. So we can actually prevent the craniofacial expansion and prevent the vision loss if we control the growth hormone excess. And this is another slide that kind of shows the same thing. So this is a patient with severe growth hormone excess who's had extensive expansion of his craniofacial fibrous dysplasia. Here's an example of a patient who has had obstruction of their otic canal, so the external canal that leads to the inner ear, due to overgrowth from growth hormone excess. So our first line treatment in patients with growth hormone excess is medication. So there are several options. There's octreotide, lanreotide, and pegvisament. And the general approach with these medications is to try to either decrease the secretion of the growth hormone excess or to block the activity of growth hormone to act on its receptor. So different classes of medications can be used together if needed. If patients can't be managed medically, that's when management can get very difficult. So in patients who don't have McCune-Albright syndrome or fibrous dysplasia, growth hormone excess is very often managed surgically. So what you will usually see in those patients is there's a little area of overgrowth in their pituitary gland, and a surgeon can go in there and scoop that little overgrowth out and then take out all the growth hormone producing cells, and they're cured. So it seems like an intuitive treatment. The problem is in McCune-Albright syndrome, those growth hormone producing cells don't occur in one little spot. They infiltrate the entire pituitary gland in the middle of the brain. So, surgery, for surgery to cure this, you have to take out the entire pituitary gland. And the pituitary gland doesn't just produce growth hormone. It produces a lot of different hormones that control many different systems. It produces hormones that control the sex steroid production. It produces hormones that control the thyroid, the stress hormones. So, patients who undergo a hypophysectomy or a total pituitary removal require long-term, lifelong replacement of multiple pituitary hormones. So we really only reserve surgery for patients that are unable to be controlled with maximal medication. The third treatment option, which is again very frequently used in the population of patients who don't have McCune-Albright syndrome, is radiation. So you can apply radiation to the pituitary gland and kill off those growth hormone producing cells. The reason that we don't prefer this treatment in McCune-Albright syndrome is that just about every patient that has growth hormone excess will also have fibrous dysplasia of their skull base, because the pituitary gland sits right on top of the skull base. So if you have mutation in this gland, you probably have mutation in this bone too. And we know that when fibrous dysplasia is exposed to high doses of radiation, that increases the risk of malignant transformation into a bone cancer. And there have been several unfortunate case reports in the literature of patients who developed fatal cancer in their skull base after receiving radiation therapy for control of growth hormone excess. So this should really be an extreme last resort treatment. Right. And then the last endocrinopathy I'm going to talk about is Cushing syndrome. So this is an increased production of stress hormones. So Cushing's syndrome is very, very rare in McCune-Albright syndrome. It affects only about 5% of patients. This presents only within the first year of life. This is an endocrinopathy that is limited to babies. And the reason for that is the gland that overproduces this stress hormone is the fetal adrenal gland. It's a gland that, when babies are forming in utero, is responsible for making all of their cortisol. However, under normal circumstances, it involutes shortly after birth, so it goes away. It's not a permanent gland. In McCune-Albright syndrome, this is the gland that carries the mutation that causes the problem. So you'll only see this present in babies if you have made it to 1 year of life without a serious illness or obvious Cushing syndrome. You can cross this off of your worry list. This is one of the few conditions in McCune-Albright syndrome that can be fatal. It's really important to diagnose it and treat it. In general, most patients are treated with adrenalectomy, so we go in and surgically remove their adrenal glands. And that leads them with lifelong adrenal insufficiency, and they need to be given high cortisol replacement for life. However, that's worth it because the Cushing syndrome can be fatal. One positive note is that this is another one of the endocrine conditions that can actually go away on its own. About a third of the time, the Cushing syndrome will spontaneously resolve. So there are some patients, if they're not critically ill with Cushing syndrome, we can manage them medically and just see if the Cushing's will go away by itself. Another important point to make about Cushing syndrome is those high levels of stress hormones do have effects on the developing brain, and these kids can have neurodevelopmental sequelae. So they may have speech issues, learning issues, and these can be really helped if they start early intervention and receive therapy early. So this is my last slide for this talk, and this is a slide from the article that Dr. Collins mentioned in the first lecture that we published in Gene Reviews that has evaluation and treatment guidelines for patients with McCune-Albright syndrome. And I wanted to bring this up because it speaks to the point I made on the first slide, is that one of the most important parts of taking care of someone with McCune-Albright syndrome is understanding what tissues are involved and what tissues aren't involved. So whenever a patient presents, they need a head-to-toe workup to figure out whether or not they have endocrine disease, whether or not they have bone disease, and where those lesions are present. So I think it's an important message for patients to get this out, that they need to advocate for themselves to make sure they're receiving the appropriate workup so that they can then receive the appropriate treatment. So thanks very much.
So I'm going to give a few disclaimers first. I'm a pediatric gynecologist. I'm a fully trained OBGYN. I am not an expert in MAS like Dr. Collins and Dr. Boyce. I've done a little bit of work. Is this not on? Can you hear me?
It's for the people online. So
Oh, okay. Can you? Okay.
You guys hear me?
Just see.
Yeah, you're up.
Okay. So I'm going to give you the perspective of a gynecologist who takes care of a lot of patients who have complicated medical issues. And so we don't have a lot of information about this, but we just kind of take what we know about other situations and kind of try to give you the best advice that we can. So when we think about women's health issues, there's a lot of different issues, but today I'm going to talk about ovarian cysts, abnormal bleeding, fertility, birth control, pregnancy, and cancer screening. So those are the things that I thought that we could have a conversation about that might be useful. So I'm going to start with ovarian cysts. Dr. Boyce mentioned that the ovarian cysts are a big part of this. She has some data showing that in the girls with precocious puberty, there's a high rate of ovarian cysts. The problem is that in adult women, after girls go through puberty, cysts are really common also. Okay? And these 3 cysts on the right are what we call corpus luteum cysts. So I put this picture is sort of the bane of medical students' existence, so I can't point to it down here, but it shows all the hormones and what happens during the menstrual cycle. And in the first half of the menstrual cycle, the egg grows and we get one kind of cyst. And after the egg comes out, there's a little bit of bleeding in there and we get a second kind of cyst. So it becomes very hard to judge what is sort of a normal physiologic cyst versus what's an abnormal cyst in all patients. And so that's difficult. And many of these type of cysts go away, and so do some of the cysts with McCune-Albright. I think the reason we care about cysts, so cysts are not cancer. There's a big difference between cancer and cysts. Cysts are like a little sack of water. And the reason we care about them is because if they break, they can bleed a little bit, they can cause pain. And then the big thing is that they can twist or they can torse, as Dr. Boyce mentioned. And if an ovary torses, then you can lose that ovary. Now, women have 2 ovaries. There's some pretty good information that if a woman loses 1 ovary, it's not like you half the eggs in half. Most women who've lost 1 ovary go through the menopause only like 1 year before a woman who had 2 ovaries. So losing 1 ovary is not a huge deal. The problem is if you've lost 1 ovary, you lose the other ovary and that's it. And there's about a 15% chance of somebody losing the second ovary if they've had one removed because of a torsion when they were young. So I think the most important thing is that if we ever do surgery, we want to untwist ovaries. Ovaries have a very high chance of working if you untwist them, even if they look like they're dead. And this is an important thing because pediatric surgeons and gynecologists have not absorbed this information very well. I spend my whole life trying to tell other doctors not to take ovaries out. You can untwist an ovary and it causes no harm for the patient except occasionally there's a fever. And there's about an 80 to 90% chance that ovary still works. So this is where you guys can advocate for yourself and for your children, and it makes a big difference if you say, I heard a pediatric gynecologist once say that it should just be untwisted, okay? Because it does put pressure on them. And then if you do need to remove a cyst, we do a cystectomy, and that's a picture where you just peel it. The way I describe it to patients is like an orange. The peel is the normal ovary, and the orange part is the cyst. And you just open up the peel it out, take what's inside. It's usually full of fluid, so you take the fluid out and it's skinny and you can just pull it out through the belly button. You don't even need to do a big surgery. We do these all the time. We had 2 on Thursday night for twisted ovaries, so this is very common. And I think the other thing that's really important, so Dr. Boyce showed this. These are 2 little girls who have precocious puberty. One has a tumor and one has MAS. The tumor needs to be removed. The MAS should not be removed. And so my point with this is that these are very complicated decisions. I can tell you Dr. Boyce takes care of both of these children, and she helps me make these decisions. And I think this is important, is that if a physician comes up and says, we think this is a tumor, it really needs to be talked to with an expert who's really thought about this, and before you start removing the tumor. So that was the biggest issue. The one thing I will say, and again, this is where the expert comes in, there are some women who have the mutation just in one ovary and not in the other. And so that ovary keeps producing cysts over and over again. I just talked to a colleague of mine at Seattle Children's who had done this recently, where she did remove the ovary in that patient because it was causing a lot of problems and the other ovary was not causing problems. But that's a decision that needs to be made with really careful consideration and with experts. The one at the top is the tumor. The one at the bottom was a 1.5-year-old who came to see the urologist because she was having vaginal bleeding. Nobody understands that there is such a thing as a pediatric gynecologist, and the urologist didn't know what she had, and they happened to be sitting with me, and they said, she's having bleeding, we don't know what's going on, and I said, does she have any skin lesions? And they're like, oh yeah, she has cafe au lait spots everywhere. And so this is why you need to see the people. You guys are going to know more than the doctors on a lot of these issues. And that's okay. We do this. Half of what I see, the patients and their families know more than I do. And my responsibility is to go read about it and put my knowledge of GYN together with that. So the second thing is this whole thing on what happens to the periods in the McCune-Albright patients. And we had a young fellow, somebody who was training with me in pediatric gynecology, who spent a year with Dr. Boyce and Dr. Collins, who called many of you guys to ask in the NIH Natural History Study questions about female women's health and things like that. And what we found is that we asked a lot of questions, and we had about 38 patients who gave us full answers on everything. Of these, 92% had precocious puberty. So this was the subgroup with precocious puberty. And 86% talked about their periods and had either irregular periods, abnormally long periods, or abnormally heavy periods. So a really, really large number of women had very heavy periods. And 34% said they had anemia because of really bad periods. And 3 patients had to have more than 1 blood transfusion because of heavy periods. The other things we found out about abnormal bleeding is that the most common treatment our women received was birth control pills. With 83% of the women had been treated with birth control pills at some point to control the bleeding. And then 9 out of these patients had a hysterectomy, some of them at a very young age. And it didn't seem like a lot of our patients had been treated with other things that we can use for bleeding. So, I'm going to talk to you a little bit about some of the things that we do for bleeding. I did want to talk a little bit about the reasons why people have very heavy periods in general. So in general, you can have an anatomic problem like fibroids or a polyp, and we can see that on ultrasound, and those can get treated one way. We can have anovulation, so we have high estrogen levels, and an egg might not come out of the ovary, and so we don't get progesterone, and so then we get this abnormal bleeding. We usually treat that with hormones. I did want to mention endometrial hyperplasia. So endometrial hyperplasia is when the lining of the uterus grows thick and becomes precancerous. And this goes to the point that Dr. Boyce made about tamoxifen. Tamoxifen is actually associated with precancer of the lining of the uterus. Tamoxifen is used for prevention of breast cancer, and it has been associated with that. And although we didn't have any of the women report that they had this type of precancer, it's something that we should consider and we should be testing for, and it's really easy to treat. So we should be thinking about it in McCune-Albright. And then the last thing, which I think is not relevant, is some people bleed too much because they have a bleeding disorder and they can't clot. So how can we treat abnormal bleeding? We can use basically birth control hormones. That's what we usually use. And what these do, so birth control pills or the ring, and I'll talk about birth control in just a second, things with progesterone, the progesterone IUD, all those things thin the lining of the uterus and decrease the amount of bleeding because of that. And they work pretty well. I did leave this GnRH agonist there because in patients who who have bleeding because of anovulation, sometimes that will help, but that might not help in patients with McCune-Albright. And then I just want you to be aware that we do have these, besides hysterectomy, we do have these new surgeries now where you can kind of burn the lining of the uterus. It shouldn't be done until somebody has tested for cancer, if there's any risk or thought about cancer. And the only problem with that is that if you do it in somebody who's very young, it's very likely that the bleeding will come back. It works really well for women who are closer to the menopause. But just in case your doctors bring these up, these are options. They're just not long-term options. I did want to talk a little bit about fertility. So I talked about how some women may not be ovulating, and that might be why they're not getting pregnant. Of our 38 patients, 17 tried to get pregnant, and 14 got pregnant. And about 7 took longer than a year to get pregnant. So technically, 80% of women who tried to get pregnant within a year. So more than a year is what we would consider infertility. But none of these women did in vitro fertilization or fertility. So it seems like the fertility is pretty normal. Okay? Now the problem is 8 got pregnant without wanting to be pregnant. So we really should be addressing this. This is pretty on par with what's happening in the United States in general, okay? So we do need to kind of get this message out that if you don't want to be pregnant, you should be using some sort of method of birth control. Which leads me to the next subject, which is birth control. So there's tons of birth control options nowadays. You know, when I was training and when I first graduated, we had like 2 things. Now we have a million things, and I'm going to go through each one of these separately. I think everybody's heard of spermicides and condoms. I will say with spermicides, we're using them a little less because they do cause some irritation of the vagina, and there has been a higher rate of HIV acquisition in people who use spermicide as their method of birth control. So we're not as crazy about it. But we divide birth control into these categories. So the first category is estrogen and progesterone birth control. Now, all birth control is even these are progesterone dominant, meaning they have more progesterone than estrogen, so they all thin the lining of the uterus, and they all cause less bleeding. So we have the birth control pills that everybody's heard of. We have a patch that gets placed once a week and removed. That one gives you slightly higher estrogen levels in the blood. And then we have a ring that gets placed in the vagina. It's left there for 3 to 4 weeks and then taken out. If you want to do 3 weeks with 1 week off to get a period, or you can keep using them. So all these methods have a week off so that people can get a period. The only reason they did that is because they thought women wouldn't want to not have a period. There's no medical reason for that. So you can actually take all of these continuously. The problem is if you do any of these and try to skip the period, many people can't go very long with skipping the period, and they'll start bleeding. And if they start bleeding, you need to stop it for 4 days, because otherwise they'll keep bleeding for like 3 weeks. So that's important. Like they make these birth control pills that have the same medicine for 3 months and then a week off. A lot of people can't make it to the 3 months, and then they start bleeding every day, and they say this birth control pill is not working. Well, it's not that it's not working. It's just that once you start bleeding, you need to just stop it for 4 days and then restart. Okay. The good thing about all these methods is there's less bleeding and anemia, there's less pain with the periods, there's less acne and hair if people are getting a little bit of hair in their face, less of that, and less cancer of the ovaries, less cancer of the uterus in the general populations, and less ovarian cysts in the general population. Again, we have no idea what this does to McCune-Albright cysts, probably nothing, but we don't know whether this blocks the receptors and then prevents them from growing bigger. We don't know. Okay. The risks with anything with estrogen is blood clots. So women who take birth control pills have a slightly higher risk of blood clots, and this is a dangerous risk. It's a significant risk after age 35 if you're a smoker, so we won't give you birth control pills if you're a smoker after age 35, regardless of any other conditions. So this is the reason, actually, people think of birth control pills as being sort of the safest method of birth control because it's been out for so long. For us, it's actually the most dangerous method of birth control. We actually have lots of other stuff that's better and safer. So then we get to the progesterone. So I told you the other ones were estrogen and progesterone. These are progesterone only. And we have a pill, and it's called the mini pill. The problem with the mini pill is you have to take it every day at the same time. Otherwise, you can have an egg come out and maybe a slightly higher chance of pregnancy than regular birth control pills. Then there's the Depo-Provera shot. The Depo-Provera shot is given every 3 months. And then there's the implant that goes in the arm. The Depo-Provera shot gives you very high levels of progesterone. The implant gives you very low levels of progesterone every day. And then we also have 4 IUDs in the market now with progesterone hormone. And those tend to just work in the uterus, that not very much gets in the rest of the body. Okay? And the risks are abnormal bleeding, which is not dangerous. It tends to be less bleeding than people would have, but it's annoying because it can be every day. With the Depo-Provera, remember I said the shot has really high levels of progesterone. That brings down your own body's estrogen, not the estrogen from the McCune-Albright excess estrogen from the ovaries, ovarian cysts, but it shuts down the system a little bit so that the ovaries just don't make as much estrogen in general. And then that actually may cause problems with decreased bone density and osteoporosis. So it's different than the fibrous dysplasia, but I just wanted to mention that. The benefits is less blood loss and less cancer of the lining of the uterus. And then the last sort of stuff we have is the intrauterine device. There is one device that has no has copper and no hormone, and then there's 4 with hormone. And the concept now is that long-acting reversible contraception is best. We know that the teen pregnancy rate in this country is going down. Some of it is because teenagers are having a little less sex, but most of it is because they're using long-acting reversible contraception. It works really well because you don't have to think about it every day. So this is a really important concept. Just a quick thing about emergency contraception. The Plan B is over the counter and people can get it over the counter. I don't know how well it would work in McCune-Albright, but I think it's worth using it. And this is what we talk to about patients now. We talk about best, good, and not so good. So the best are long-acting reversible contraceptions, IUD and the implant, and sterilization. Pills, patch, ring, shot, not as good. And then condoms, less good. Okay? Obviously, everything except for condoms does not protect from sexually transmitted disease. The CDC has guidelines for people with medical problems, whether they can use, like what method is safe for them to use. And there's no guidelines for McCune-Albright, but your doctor should look, if you have any other conditions, should look in this guideline to see. I'm running out of time, so I'm going to move a little bit quickly. So the pregnancies, there were 22 pregnancies, 4 miscarriages. That's pretty normal. We know that about 1 in every 5 pregnancies ends in a miscarriage in human beings. 6 had abortions because they didn't want to be pregnant. So I think this whole issue of using birth control. 1, the baby died in utero, and we can't say anything from that. There were 13 deliveries in 9 women. 7 of them delivered vaginally and 6 by C-section. The reason for the C-section, 4 of them, it was because of the fibrous dysplasia, and 2 because the baby's heartbeat wasn't doing well. Okay, so certainly if the pelvis is affected, you may need a C-section, but if it's not affected, probably can do a normal delivery. One of the things that I mentioned earlier is when we are doing a delivery, sometimes we'll really bring the legs up, and that shifts the angle of the pelvis, and so it's something important to talk to your doctor about, that they may not want to be moving your legs around too much. And the last thing I wanted to talk about is sort of the issue of cancer screening and cancer risks. I did mention this possible risk of precancer of the uterine lining because of the estrogens, and then whether there's increase in breast cancer. I know Dr. Boyce published a paper. We know that there is GNAS gene in the breast, and we actually found GNAS gene abnormality in girls with certain tumors of the ovaries that were benign. So what does that mean for screening? So when we talk about screening, one of the things that has to happen when we're doing a test for screening is the test has to be cheap, so we can do it in a lot of people. The test has to find the cancer early, so if it finds the cancer later, it's no good. And it has to not find all kinds of other things that are nothing, so that you have a million tests and possibly surgery that you didn't need. So for example, that's what's brought up this whole controversy about mammograms and when should you start doing mammograms. Between 40 and 50, we don't get a huge benefit out of mammograms as far as reducing the risk, finding a cancer early enough to reduce death compared to the risks of doing these tests and doing all kinds of surgeries. So the question is, when should we start in women with MAS? Well, I certainly would say we would start on the earlier side of that 40 to 50 divide, so at 40, and we don't know whether to start earlier or not. Uterine cancer, there is no screening test, but if there's a lot of abnormal bleeding, after age 45, it's recommended that we do an endometrial biopsy. That's a little tube that gets put in the uterus, and a little bit of the inside is sort of sucked out. It's done in the office. And I would suggest that if there's a lot of abnormal bleeding, I would consider doing this earlier in somebody with MAS. The cervix, so cervical cancer is screened now starting at age 21. You should never have a pap smear before age 21. It's every 3 years until age 35. And at that point, you can do the HPV virus and the cervical and the pap smear and go to every 5 years. I think women with MAS should follow the same regimen as everyone else, and I recommend the HPV vaccine for everyone. Okay, it's been tested in millions of girls and boys. If you give it early enough, it's 100% protective from vulvar cancer and cervical cancer. And the risks are very low. The main risk is pain at the injection site. And if you give it late, so if you say, oh, this is a sexually transmitted disease, I don't want to give it because my girl or my boy is not sexually active now. If you wait till they are sexually active, the benefit goes away. It doesn't go to zero, but it goes away. So the time to give it is 7th grade when they're getting their other vaccines. And then colon cancer, there are some reports of polyps in people with MAS, and traditionally we're doing colonoscopies after age 50, so the question is, should we be doing this a little bit sooner? So that's it. I won't go through the conclusions. It's just repeating what I just said before, and I'm out of time. But
Should I use that one? Or do I need this one? Yeah, because they don't have a stool, so just use just put it on, right?
yeah, I think so. That's what I did.
Pretty loud. So, hi everybody, I am Lauren Ruotolo, and I just want to first thank everybody for being here, especially Deanna, who has just been absolutely unbelievable. So I just want a round of applause for her. She really put this whole thing together, and she's incredible. And I also just want everybody to take a deep breath, because, wow, information. So I promise you that during the 10 minutes I'm going to speak, I'm not going to mention the word cancer. Maybe I'll mention the word cysts, but I'm really going to try to keep away from all of that, because it's, as sitting here as a patient, it's great to hear all the information, but it's terrifying to take in. And so, as you guys know, I'm on the board of Fibrous Dysplasia and organization, and I just want to briefly go through a little bit about my story, but really highlight the endocrine side and what it's like to live as a woman with this disease. And so sorry for all you men out there, but we're going to take a ladies' approach right now. So I had precocious puberty, like 93% of us have, for those of us that have McCune-Albright syndrome. Began at 8 months old. My mom noticed it. She was like, okay, I don't know. The next month, I got it exactly the same day. 30 days later, she took me immediately to the doctor, and they diagnosed that. At first, they just said, oh, go to a surgeon. She took me to a surgeon. They thought maybe a pin was inside of me. Now, this is in 1976. So you can imagine there was probably little to no explanation about McCune-Albright syndrome at that point. They said to my mother, maybe you're getting like a pin inside of her through your diapers. She's like, excuse me, like my daughter wears Pampers. I'm not abusing my daughter. There is no way that she has pins inside of her. And so they then took me to another specialist who knew exactly that this was precocious puberty, and they immediately started me on Depo-Provera shots. So all of you today, you probably take it by the mouth. They're still shots. Well, I took 2 shots a month until the time that I was 8 years old. And so if you think about it, my parents injected me with almost 200 injections before I was the age of 8. That's a lot of injections. I don't really remember them. I remember, like, sometimes, like, they would practice when the doctor started giving to me, and then my parents had to give it to me, like, practicing in an orange. We were, like, big fruit people, so we would practice in, like, a lime, like, whatever it was. My family had to practice giving me those injections, and by the end, it was almost 200. And so I think about the number of injections, and then as a woman, I think, well, how did that affect my body and my appearance? And it basically left me, like, my arms and my butt like cottage cheese. There's like little tiny pockets, and I don't know if that's a symptom of it, but that's what I have now from where all the injections were given to me. And, you know, at that time, they took me off of the Depo-Provera. They put me on the pills, I believe, Mom?
Yeah, but I forget the name of it.
They put me on a pill. Nobody can remember what it was, but I was on that pill for a little over a year. And just picture this. I feel like I'm in an episode of The Golden Girls. So picture this. I am 8 or 9 years old. I have a full face of pimples. Thank you for that. And I'm basically developed. And I am now starting to go through menopause. All of a sudden, my body had the adverse reaction to what was supposed to maybe give me my period again. And so here it is. I am almost, you know, I looked like I was a mom because I was the tallest person in the class, and now I was fully developed. And so what is that like to feel fully developed at the age of 8 years old, 9 years old? It's, you know, you have these like feelings of like, I'm different. You also have, because your hormone levels are constantly going up and down, you're nervous. And you can't identify the nervous because you're not having what they would consider like an anxiety attack. You just have this like unnerving feeling, and you don't really know why that's happening to you. And I'm sure a lot of the ladies in here can attest to that feeling. But you have this sense that's very unnerving, and you feel a little bit of insecure because all of a sudden now I'm super tall, which clearly didn't really work out in my favor because now I'm super short. But at that age, I was super tall, and you would go for, you know, swim party or sleepover or camp, and girls just get dressed in front of each other. It's like no big deal. And all of a sudden, if you look different, you're like this. You're like holding yourself, and you don't know what to do, and you just feel a little bit different. So now, imagine that a little bit later, and couple all of that together, and what am I getting? I'm getting multiple nervous attacks, and now I'm getting hot flashes. So here I am, a kid still in elementary school, getting hot flashes in class, getting them in the middle of the night, you know, waking up, my back was sweating, my neck was sweating. These are not things that a normal girl under 10 years old would really get. And it was, you know, I was angry, I was crying suddenly, and then I was happy, and then I was crying again. And so all of these things, and I feel like with McCune-Albright syndrome, we always talk to the bone side of the disease. But like I said, I can't speak for the male side, but for the female side, these are real feelings and real things that happen to you. And a lot of times they're swept underneath the carpet. And why is that? Because everybody is a little bit different. As Dr. Boyce says, no two cases present themselves the same. And so some people are getting their period at 8, some are getting it at 9 months old, some are getting it, normally, and you don't really know, and everybody has different feelings, but anybody that has presented precocious puberty and then has developed, like you could start developing when you are under a year old, and then all of a sudden you have friends and you're doing all these things, this is the kind of conversation that I really want to open up, because these are the real issues that affect the patients. And these are our feelings that we have towards it. And so how do you deal with that? How do you be an 8-year-old girl, a 10-year-old girl, and, basically look like somebody's older sister or their mom when their friends look at you? And so, today, I still have, that's one of the biggest things that I personally speak about if I go to the NIH or if I go to gynecologist. I talk about what is now that next phase, So I started birth control at the age of 18. If I change my birth control, it is like changing into a new person. Like, I don't know who that person is all of a sudden. It's like my entire body, has this, shock into it. And my hormone levels get crazy. And I, again, will get, hot flashes. And so I think that your hormones are just as sensitive as your bones, and that's really what I wanted to highlight during this talk, because you could break a bone or you could be sweating in the middle of the night, and it's still the same kind of effect. Emotionally and physically, it has that same kind of effect on you. And so, like I said, what do you talk about when you have cystic pimples? You have, and I had this brief conversation outside, so a lot of the women over there are FD warriors. I said to them, has anybody here have had a cystic pimple, all of a sudden, a day later, 2 days later, leg swelling, and there's an FD flare? Every single one of them said yes. So, these are the things that nobody really speaks about, but it's the daily routine of what it's like living with this rare disease. And again, that's really what I wanted to speak about. And I know that I promised Deanna, so I would go and be short today. Well, not just my stature, but my talk would be short. So I just really wanted to go away and just really talk about that, open up this conversation. For those of you going to the happy hour, we will talk about this, I think, in more detail. But as somebody that is now growing older, the concern is, okay, now I'm 41, and menopause. And that's well, so I kind of went through menopause already. Is it going to be what I remember it? Is it just going to be the natural cycle of what it's like for everybody else? And there's not that many of us that are getting of that age. And so, well, there's a few of us here. And so, I think it's just it's like a TBD. What is it going to be like? And so maybe in 10 years from now, we can come back and maybe I'll be beginning it. That's my hope, that I won't have an episode like that again. But, for everybody again out there, this was just a brief under 10 minutes of what it's like to live from the endocrinological side of the disease and being a female. So thank you. Oh, yes. I don't want to give it back.
Okay. So, my job was to do kind of the cleanup here. So I'm going to do some of the endocrine things that haven't been discussed so far, and a couple other things as well. One of which I'm sure Lauren will be glad to hear about. But somebody's got to do it because I think it's important. Anyways, you can close yours. Anyway, so I just wanted to talk about these 4 things. And so this first one has actually been talked about a little bit. But one of the questions is, why do we care about phosphate? I mean, what's the big deal with phosphate? Well, bone is actually kind of a simple tissue. It's this crystal. It's a biological crystal, calcium and phosphate, and with a few cells. I mean, you can take a look at this picture. There's very few cells in a hunk of bone. I mean, it's mostly this crystal of calcium and phosphate. And usually we don't care about phosphate because phosphate's in everything we eat. It's hard to get food in it that doesn't have phosphate. We care about calcium. We have to make sure we take enough calcium because it's not in a lot of foods, but phosphate's everywhere. But the problem is with some patients with fibrous dysplasia is that, like Dr. Boyce talked about, they pee out phosphate in the urine. So in those patients who have a lot of fibrous dysplasia, and usually have to have a lot of fibrous dysplasia to have this problem, the phosphate problem. But if you have a lot of fibrous dysplasia and you're making a lot of FGF23, you lose phosphate in the urine. And so the importance of that is, again, this has been discussed earlier, that if you're losing phosphate in the urine, that the bone disease is worse. You have more fractures, you have earlier fractures, you have more bone pain, and so it's an important issue. The treatment of the low phosphate is really a pain in the neck, I have to say. You take phosphate supplementation, but you have to take it at least 3 times a day, sometimes 4 times a day. A lot of people don't tolerate it well. It's hard on the stomach and can cause some diarrhea. And if you take too much phosphate and too much calcium, then you're at risk for kidney stones. So it is an issue. The good news about this is that in most patients who have this, at some point in their life this goes away. But it can take up to like your 20s or so for this to go away. So that's the good news, is that it goes away. The other good news, too, is there's a new drug coming that's in trials for other diseases that is good for disorders that have low phosphate from high FGF23. So I think that drug, when it's available, will be a potentially good treatment for patients with fibrous dysplasia. So again, the importance of this is to check for it. It used to be that when you got a blood panel, that phosphate was on the blood panel and everybody looked at the phosphate, but it's not on the blood panels anymore. You have to specifically request to have the phosphate checked. So I think, again, as was emphasized earlier, sort of in your first couple visits, you want to get all of this stuff checked and make sure that it's not there. We have seen some patients, as Dr. Boyce said, that they may come in at a certain age and the phosphate is like on the low end of the normal range. It's normal, but then when they go through the growth spurt, the phosphate can actually get low, and then it may need to be supplemented. So that's the story with the phosphate. All right, this is something new. The finding that there is pancreas involvement in fibrous dysplasia, McCune-Albright syndrome. Actually, the most common cause of pancreatitis is too much alcohol. So one of my first encounters with a patient with McCune-Albright syndrome and fibrous dysplasia was with Charlie Harless. When he came to see me at the NIH, and he said he had this history of pancreatitis. I didn't think much of it, and I said, well, do you drink very much? No, I have a few beers. And I thought he was probably lying to me, that he was probably drinking a lot under the table, and that was the cause of it. Charlie used to make his own beer. And what the name of the beer is what? Bad to the Bone, was that it? Bad Bone beer. It's actually quite good. Anyway, but then we began to hear this story of pancreatitis more, and it was clear that this really was a thing. It wasn't just somebody lying about how much they're drinking. Anyway, so we began to look at this more closely. There was another group in Paris that was looking at this more closely as well. And we began to see, lo and behold, that a lot of these patients with McCune-Albright syndrome have these things that are called IPMNs. And I'll show you what that looks like. So there's the full name for it. And you'll be glad that we'll call it IPMNs rather than intraductal papillary mucinous neoplasms. So what's the big deal with these? Well, what's understood about these in the general population is that IPMNs are probably a risk factor for pancreatic cancer. Is this the case in McCune-Albright syndrome? We're not sure. It might be. There have actually been reported 2 cases of pancreatic cancer in McCune-Albright syndrome. But again, the problem with this is pancreatic cancer is pretty common. Breast cancer is pretty common. So when you have a common condition and a rare disease, are they connected or is this just coincidence? So I mean, it's going to take time. But until we're certain, I think it's important for us to recognize that there may be an association and to look and see if this is the case. So, and this is how we look for it. So this is called an MRCP. It's a type of MRI. And it can detect these abnormalities in the pancreas in patients with McCune-Albright syndrome. So on the left panel there is a normal MRCP, and you can see how skinny the pancreatic duct is, how skinny the common bile duct, and on the right is a patient with McCune-Albright syndrome who has an abnormal MRCP, and you can see how swollen the pancreatic duct is, how swollen the common bile duct is. And then in the bottom two panels, you see on the left a normal pancreas, which may be kind of hard to see. Let's see, can I get the pointer to go over there? Yeah?
It doesn't look like.
Yeah, okay. Oh, well, I can't. I'm going to waste time on it. Anyway, so you can see on the one on the right, and that IPMN there, and I had some arrows there, but they're gone now. But anyway, so that pancreas on the right is full of these IPMN. So this is a patient with McCune-Albright syndrome. So if someone without McCune-Albright syndrome, as Alison was talking about with the testicular ultrasounds, if someone with that goes into a doctor and they see that MRCP, that pancreas is coming out. But is that the right thing to do in McCune-Albright syndrome? We don't know. We're really trying to figure this out. So we have had a number of patients. I'll show it right here. So far we have screened pretty carefully 54 patients with these MRCPs. And about half of them had abnormal MRCPs, and most of those abnormal MRCPs were patients with IPMN. So they're pretty high prevalence of abnormal MRCPs and cysts in the pancreas with patients with McCune-Albright syndrome. 7 of those patients have gone on to have endoscopy, and based on the concerning appearance on endoscopy, those patients went on to have surgery. And both of those patients had high-grade dysplasia. One was in the pancreas and one was in the esophagus. So this really at this time is an evolving story. But again, what we recommend in most patients, especially those with McCune-Albright syndrome, maybe not with monocytic fibrous dysplasia, but definitely with McCune-Albright syndrome, that everybody have a screening MRCP at baseline or at some point in time. And I think that if it's negative, then you're done. You don't have to worry. Story's over. If there's something there, then you're referred to a center that has a lot of experience with this. Again, this is a subspecialty of an abnormal condition. So you really want to go to a place that either has experience with this or a place that's going to listen to a place that has experience with this. So that's important. It's an evolving story, and it remains to be seen. I think one of the main things is just to put it on the radar screen. Another thing on the radar screen. Sorry about that.
I had it.
Yes, you did. And you did well.
I did.
Yes.
I passed.
You passed. Okay. Now this is Lauren's favorite topic, but if we didn't do it, we would be remiss. So here's the importance of this. There's a couple things. So this gene that causes McCune-Albright syndrome, the normal copy of this gene, is expressed in practically every tissue of your body, from the brain to the tips of your toes and every organ. So given that, practically any tissue in your body is fair game for being involved if there's a mutation. And what we've known about this exact same mutation that causes McCune-Albright syndrome is that it's a weak oncogene. So what is an oncogene? An oncogene is a gene mutation that predisposes you to cancer. But cancer isn't caused by a oncogene. By the time you have a cancer and they look in that cancer and they sequence all the genes in that cancer, you have 10, 20, 30, 40 gene mutations. So all of us in this room, whether we have McCune-Albright syndrome or not, are walking around with some predisposing genetic mutations to cancer. This just happens to be another one. And we happen to know that you have this one. The ones of us who don't have McCune-Albright syndrome, we don't know which ones we have. So the point is that this kind of gives you one mutation going out of the gate. So you've got this one mutation, it's there. And if you were to acquire other mutations in those tissues, then this may further predispose you to cancer. So this is the basis for the increased risk for cancer with McCune-Albright syndrome. We think that in general that this is a pretty weak oncogene. It's a pretty wimpy oncogene. It's not a big oncogene like the ones that cause ovarian cancer. but we do think that it's one of the contributing ones. So then what are the cancers that we are pretty sure are associated with McCune-Albright syndrome and we have to keep an eye out for? So probably one of the most common is bone. And I think the association of bone cancer with McCune-Albright syndrome is probably a bit overblown. And I think it's overblown because there was a period of time, a long time ago, when they attempted to treat fibrous dysplasia with external beam radiation. There was a period of time when external beam radiation came along and they treated everything that came along with it. They treated the adenoids in kids with radiation, and it predisposed people to cancer. It's not something that's been done for a long period of time, but there was, during that period of time, a sort of uptick in the cases of cancer associated with McCune-Albright syndrome. So there probably is some small increased risk of cancer with patients with McCune-Albright syndrome. In the probably 30-plus years we've been seeing patients at the NIH, and we see patients with pretty severe disease. We've only seen one case of it. So it is there. It is real. I don't think that it's something to keep you up at night, but we know what to think about when we see it. If you have fibrous dysplasia in your 20s, 30s, 40s, and you've been going along and it's pretty quiet, and all of a sudden something takes off and it's growing real big, that would be a time for consideration. Probably also in terms of the cancers in general that are associated with McCune-Albright syndrome, if they occur, they're not really aggressive metastatic cancers often. They're probably more often completely treated and cured with surgery. So that is another, I think, important feature of this. The other one that we've seen there are 2 reported cases in the entire medical literature of thyroid cancer associated with McCune-Albright syndrome. Thyroid cancer is not a rare cancer, so is that a real association? It may or not be. Nonetheless, we have very good screening procedures to look for thyroid cancer. Ultrasounds, the thyroid's right there. It's easy to see. If there's something that looks abnormal, we can stick a needle in it and look at the cells and see if they're abnormal. So I don't think that's of major concern either. Testicular cancer, there's only been 1 reported case of testicular cancer with McCune-Albright syndrome. Another good thing about the testes is they're right there. They're easy to look at with an ultrasound, so it's easy to spot cancers. The pancreas I just talked about. There's been 2 reported cases. Is it real? Is it not associated? And then that brings us to the final one that we know about, breast cancer. And this is something that was the result of a collaboration with the group at Leiden. So this is an example of by bringing together 2 groups of patients who study rare diseases and combining it gives us more power to look at these things. So these are the 2 large groups from Leiden and the NIH, and there's 134 patients in the Leiden cohort and 121 from NIH. And taking all those together, there are 15 cases of breast cancer identified. The women who had breast cancer were a little bit younger than the normal population, and this was probably felt that relative to the baseline level of cancer in the United States and the baseline rates of cancer in Holland, that this was an increased risk, somewhere between 3-fold and 4-fold increased risk of the general population. But again, this is the first study. This is one study. Breast cancer is super common. How real is this association? How strong is this association? I think it probably may be real for a couple reasons. And that is because in some of these breast cancers, where the tissue was available and where they looked, they did find the mutation that causes McCune-Albright syndrome. So that makes it probably real. We know that earlier and longer exposure to estrogen may be an increased risk for breast cancer. And so girls who have had precocious puberty on the basis of that may be at a slightly increased risk. In that study also, and again, I think this is maybe true, might not be true, it could be the case that if you are a woman who has fibrous dysplasia in the thorax, that you might be at an increased risk for breast cancer. The thinking there is that if those mutated cells have migrated to that part of the body in the bone, then perhaps they've migrated to that part of the body in the breast, and you're at increased risk for that as well. What about treatment? Well, again, when this mutation causes cancer, we think that it's probably a relatively unpotent or wimpy promoter of cancer. In these women, they had surgery, chemo, and radiation. There was 100% survival, and there was no metastases. The average follow-up was up to 15 years, and there was no recurrence. So the conclusion is that women with MAS may be at increased risk for breast cancer compared to the general population. Occurred at a younger age, but it was less aggressive and with excellent long-term outcomes. And the recommendation then is for early and regular self-exams and early screening. And again, as Dr. Lobo said, start screening mammograms probably about age 40. And I think this is the last thing I wanted to talk about. So again, remember I said that this gene is expressed everywhere in the body, and it's expressed highly in the brain, all regions of the brain. So is there a bone phenotype? Is there a brain phenotype? Is there a aspect of McCune-Albright syndrome that reflects the brain aspect of McCune-Albright syndrome? Well, we think there probably is, and we think there is for a couple reasons. So number one, when an investigator has taken the same mutation that causes McCune-Albright syndrome and put it in the brain of mice, depending where it's put in the brain of mice, there's abnormal behaviors. How you assess mouse behaviors is another story, but we'll talk about that. Anyway, for a long time, we had seen patients at the NIH who had sort of different behaviors. It wasn't quite spectrum behaviors. It wasn't quite autism. It wasn't quite. We couldn't quite put our finger on it. But there's definitely some abnormality, and we've begun testing these patients in a very detailed fashion to look at in depth. Sleep studies, neuropsychiatric testing, etc. And we think that there probably is a McCune-Albright syndrome related neuropsychiatric phenotype. Again, we don't have a test, we don't have an imaging test, although we're working on developing one, and actually that study should be started soon. But we don't have a test that say, yes, he has it, no, he doesn't have it. So it's unlike the other ones where you can do this test at 10 years age, 10 years old, they don't have it, you don't have to worry about it. This is one where it's evolving, and you'll have to look at them, and you'll have to get your children tested to see if it's the case. Anyway, it's an area of active research, and a lot more work needs to be done. And again, I'm going to close by thanking all the people I work with. So hopefully this time I'll get through it. So Penny Fouillon was one of the people at the NIH who was there when I came and trained as a fellow, and she really was the one who started much of the research in this area. And she was a wonderful clinician, a wonderful physician. Some of you who have been around longer, she was the one who would take your call at 10 o'clock on a Friday night and talk to you for an hour when you were crying from out of town. And then, of course, Arabella Leet, who many of you have met, who is a pediatric orthopedic surgeon who is dedicated to this, and she was a wonderful person and had a very untimely death. Paulo Bianco, who many of you know and Mara and I knew quite well, really dedicated his life to this and was a brilliant man, and his loss is really felt for this. And then all the other people there. And really so much thanks to Ed Fitzgibbons and Scott Paul, who will be here tomorrow, and Jeff Kim, some of my collaborators at the NIH who have been doing this for a long time and really put a lot into this and done very thorough evaluations of patients for many years. It's really an unprecedented study, and I thank the National Institutes of Health, the taxpayers of the NIH for funding this, the Fibrous Dysplasia Foundation. I'm very excited about the international consortium, which I think will have a tremendous impact on advancing this disease. So with that, I'm going to close. Thank you.
Get an MRCP.
So when to start screening with the MRCP is really unclear. Right now on the natural history study, we're not doing it before age 10. So no, I wouldn't recommend screening in a pediatric patient unless they're having GI symptoms. So of course, if there's any history of pancreatitis, or if there's just a lot of unexplained GI symptoms, I think it would be indicated at that point. We don't know exactly when to start screening, but I would probably wait till adulthood at this point.
What is the best procedure to deal with a goiter?
It depends if it's functioning or not. So if it's overproducing thyroid hormone, then we would probably start medications. And then for long-term treatment, if a patient has hyperthyroidism and a goiter, surgery is a good long-term treatment. We don't typically recommend removing goiters if they're not over-functioning, unless there's a concern, like a suspicious lesion or some other specific reason to do it.
If you're removing ovary cysts in women with MAS, would you consider removing a testicle if someone had a lesion on one side?
Like this one?
I'll give you that.
It's not on. That's what now it's on.
We're not advocating
Is it on?
removing the cysts, first off.
Yeah. So it's a good question. You know, when and
Well,
again,
first, we should say we're not saying people should have their cysts removed.
right.
Yeah.
That's right. So the question is, should a testicle be taken out if it's over-functioning?
Yes.
And the answer is no. That can be treated quite well with medication. Like it had a concerning finding, then at that time we would recommend having the testicle taken out.
This is for Dr. Gomez-Lobo. It's quite extensive, so I'll give you the card after I finish reading it. FD patients with irregular periods are recommended to take birth control pills. Are FD patients estrogen heavy? Are irregular periods a result of central or peripheral issues? Have you treated FD patients with only progesterone on cycles to day 12 to 24? And would a normal menstrual cycle contribute to a healthier bone?
So I'll start with, women with MAS with active ovaries certainly probably have excess estrogens, and it could be that they're bleeding because of the excess estrogens. Birth control pills suppress the ovaries by suppressing the brain, and it might not work for somebody with MAS. It might still produce estrogen. But the other way that birth control pills make you bleed less is by thinning the lining. So regardless of how much estrogen you have, it's thinning the lining of the uterus. I have treated one teenager with an IUD, progesterone-only IUD, and she's done very well. But that's just one person. So. And then the last question, the progesterone on day 12 to 24, I don't find very useful in general as a gynecologist, because that would mean that you're actually ovulating and that you're having regular periods. If your periods are irregular, giving progesterone certain days of the month is just useless. If you're going to do progesterone, I would say do it all the time. And the last question is, what's the effect of all of this on the bone? So we know if you have low estrogen, you can have osteoporosis, which is a different problem. If you have high estrogen, I don't know, that would be more of a question for Dr. Collins, but certainly adding the birth control pills should not make a big difference in the bones.
Do you have a recommended age to remove the thyroid?
If we think the thyroid should be removed, we generally try and wait till it's a anatomically more feasible surgery. So in other words, a thyroid surgery in a small child is very difficult, very complicated, technically challenging. It's better to get that child through to sort of full size, where it's a more reasonable surgery and a less technically challenging surgery for the surgeon.
If we stop extra growth hormone, can we stop further expansioning or worsening of bone lesions, especially during puberty?
So we have definitely observed that the expansion of the fibrous dysplasia is worse in patients with uncontrolled growth hormone excess. And we do think that if we give medications to control the growth hormone excess, we can prevent the lesions from expanding more due to the growth hormone excess. Whether or not we can remove it completely as a factor is not entirely clear.
Would you recommend a mammogram for someone with only fibrous dysplasia at an earlier age?
So I believe in our study we recommended if the mammogram is going to be done earlier due to the presence of McCune-Albright syndrome, that should apply to patients who have polyostotic disease or endocrinopathies.
I want to say something about mammograms. When you do mammograms earlier, they're not as good because the breasts are denser, and so they can't see the lesions a lot of times. So it's not a magic bullet. If somebody has a very high risk of breast cancer, like somebody who has a family history with the gene, the BRCA gene, we sometimes do MRIs, and I certainly would not recommend that for MAS based on what I'm seeing and hearing here.
Got a lot of cards here.
Yes. Cancer. Prostate cancer.
Not that I know.
And is it common to present with low phosphate at the age of 30 or after? And what drugs would you take?
Probably less likely to have it start at that age, probably really uncommon to have it start at that age. It's possible that it was there earlier and not recognized and just picked up at the age 30. If it had been tested for and wasn't there, to have it start at the age 30 would be very uncommon. But if it's there at the age 30, the treatments would be just as those that I outlined. Phosphate supplementation by mouth 3-4 times a day, and maybe this new drug once it becomes available.
Will another disease like cancer affect your fibrous dysplasia if you have a secondary condition?
So if you have a cancer, can you think of a cancer that would make fibrous dysplasia worse? I can't think of a cancer. Any hormone-producing cancer that would make fibrous dysplasia worse? I can't think of one.
There's a lot about testicles. What are the clinical...
It's one of the most important organs in the body.
Sure.
What are the clinical expressions of testicular lesions?
So Alison was the person who wrote the paper on testicular lesions, so I'll turn that over to her.
So usually it's clinically silent. It's not something that patients generally will pick up on their own, but we do see that most patients will have mildly enlarged testicles compared to other boys their age. And of course, if they're overactive and have precocious puberty, they'll present with signs of male puberty. So that's usually hair growth, increased penile length, and then increased, kids will start to grow quickly. But most of the time it causes no symptoms at all. You wouldn't know if it was there unless you were looking for them.
Yeah, I mean, that's one of the things. It's not picked up on physical examination typically. I mean, it's not like in this, so you can't feel it. So that's why we recommend, initial screening, and if the testicles, there's nothing in the testicles, are normal, you can probably not worry about it. But if on the initial screening there's abnormalities in the testicle, we recommend regular follow-up ultrasounds. And what does that mean? So maybe in a man who's growing up once every 3 to 5 years, something like that.
Yeah, and just one thing to add to that too. So one important point is on physical exam, the patients who with testicular lesions will just have like a diffusely enlarged testicle. There's not like a one area that's bigger. There's no like palpable mass. The patient who developed testicular cancer did have a palpable mass in the testes. So that's one reason we recommend that all boys and men do testicular self-exams. And if they notice a mass in the testes, or if they notice that it seems to be changing or growing bigger, that would be a time to consider possibly a biopsy or some other workup.
Lauren, when did you first understand your precocious puberty, and how did you deal with it socially?
Well, so it's interesting. I didn't really know. I knew what really the effect was until I started writing my book. And I basically just started interviewing my family about what it was like. And I think that when I learned about not only what it was like for me, but for my parents, That's what really hit home for me, is how it affected them and how they had to deal with it. Because I was a child, I didn't know any better, to be honest with you. I don't remember it. I have, I have 100% no recollection of having precocious puberty at 9 months or even at, 6 years old, whatever it may be. So, but now I just want to use my voice as much as possible to help patients and parents out there.
Thanks. Why would a parathyroid test come back low? Is it anything clinically significant?
Well, that's hard to comment on in isolation without knowing all the other stuff that's going on, but we'd be glad to look at the tests if someone wanted to send us the results. Typically, the parathyroid glands aren't thought to be part of the McCune-Albright syndrome.
At what age would a girl with MAS begin taking birth control?
So in general, once a girl has breasts and their uterus has grown and they've had estrogen in their body, and they adding birth control pills is very safe. And so if you need to control bleeding, you can do it. We really like.
I can't hear.
I'm sorry. Can you hear me?
Well, it's the people. That's for the people online, not for the people in this room.
Okay. I'm sorry. I said, in general, once a girl has breasts and has started bleeding, giving them birth control pills is not adding so much estrogen that it's going to cause any problems. So we feel that it's pretty safe. It's not like we've studied a lot of patients that age. When you look at birth control pill research, it's all been done in adult women, and we've extrapolated that to children and adolescents, but I think most of us feel pretty safe.
How do you socially deal with that? So if you have a 9-year-old that's on both control pills, how do you...
we do it all the time.
You do?
It's not that, it's like a medication, just like any other medication. And we've put IUDs in girls as young as 9 years old if they have other conditions like a bleeding problem, or I haven't done it for MAS, but girls with bleeding problems or other reasons why stopping the period's important, we've done IUDs too. We do it in the operating room so that they don't have to go through the discomfort.
Okay.
At what age is the growth hormone excess detected?
So that's a good question. We used to think it was very, very early, that if you had growth hormone excess, it was going to be there by 5 or 6, like the other endocrine conditions usually are. But we've noticed more and more that this is one of those endocrine conditions that, although it's probably present very, very early, it's not. It doesn't always reach a place where it's clinically evident until patients are older. So I've seen it, I've detected it myself as kind of a new clinical problem as late as 11 or 12. And we've seen a number of patients come in, even in adulthood, where they likely had very subtle, very low-level growth hormone excess for a long time, not necessarily even at a level where it needed to be treated. However, over time it may have increased, and they may need to start treatment in adulthood. So that's one of the endocrine conditions that probably do need to keep an eye out for in patients who have skull disease.
And specifically, how do you check for it, or what?
So there's a very good screening test. It's called a insulin-like growth factor 1, or IGF-1, and it's a blood test that can be drawn any time of day. And if that comes back either elevated or even up the top of the normal range, then we recommend doing a confirmatory test. And the most common one is a glucose tolerance test. It's the same type of test that women have when they're pregnant to check for diabetes, where they give you a sugary drink to drink, and then they check your blood at certain time points. So that's actually a very good test for growth hormone excess.
Can you develop cysts if you don't have a pituitary gland? So no hormones to go up or down.
You mean like ovarian cysts?
Maybe.
Okay.
Doesn't say.
Yeah, so the ovarian cysts and McCune-Albright syndrome are completely independent of the pituitary. And it's a bit confusing because in patients without McCune-Albright syndrome, the pituitary is the main gland that controls the ovaries and tells it what to do. But in McCune-Albright syndrome, these mutations occur in the ovary themselves. So that when the ovaries make cysts, it's acting totally independent of the pituitary and it's not listening to the pituitary the way it's supposed to.
And will you be on replacements for life if you have your pituitary taken out?
Yes. So if the pituitary is taken out, then replacement medication is taken for life. And also in patients with growth hormone excess, that medication needs to be taken for life.
Will the pituitary ever grow back?
No. We have seen evidence that sometimes the abnormal growth hormone producing cells might grow back over time, but no normally functioning cells will grow back.
I've never been on growth hormone, and they took my pituitary out when I was 15. I'm 33.
Her statement for the camera was she's never been on growth hormone replacement therapy after having your pituitary removed. At 15.
You know, when somebody has their pituitary out, whether to put them on growth hormone replacement and how long to continue or when to stop it is a question. I would say that if, normally speaking, if the pituitary was removed at 15, the standard of care today would be to be on growth hormone replacement up until when, 20, 25, 30, I don't know, but certainly at 15, standard of care today would be to have growth hormone replacement for a period of time.
Gut flora is said to have significant impact on bone health. Has research been done with FD related to this?
The whole area of research related to the gut flora, the bacteria that are in the gut that is emerging as possibly an important contributor to physiology and biology is an evolving area. There's some speculation that it may have an important impact on bone and bone health, but the data supporting that are at a very early stage and not definitive. And then further beyond that, would that have any implications for fibrous dysplasia? It's impossible to say at this time.
I have high alkaline levels in my bloodstream. Is there a correlation with high alkaline levels and hypophosphatemia?
So probably indirectly. So fibrous dysplasia is a very active bone disease, so bone is being built up and broken down repeatedly. So it's very, very common to have high alkaline phosphatase levels, and all that tells us is that the bone is very active. We know that patients who have more FD and more active FD also make higher levels of FGF23 and are more likely to have hypophosphatemia. So I do think a patient with those findings should be monitored for hypophosphatemia, but the alkaline phosphatase itself is not going to cause hypophosphatemia.
Lauren mentioned experiencing menopause early. Is that common with MAS patients?
Oh, I don't know.
It's a great question, and we don't have the answer to it. That's why we're all passing the microphone around.
Mine was a medical.
I can explain a little bit.
Yeah, okay.
So menopause symptoms can happen in anyone whose estrogen comes down after it's been high, so the hot flashes can happen. Technically, menopause is when the ovaries don't have any more eggs, and I don't know if that happens in MAS.
We haven't
Yeah.
We haven't had enough women that we followed closely over a long enough period of time who have reached the age of menopause to have an answer to that question.
Would taking thyroxine for an underactive thyroid as a result of
Hashimoto's.
increase the risk of FD growth.
Okay, so I guess the question is if someone is on thyroid hormone replacement for low thyroid levels unrelated to McCune-Albright syndrome, will that worsen their fibrous dysplasia? And the answer is no, as long as they are treated appropriately with thyroid hormone. So one of the reasons it's so easy to treat hypothyroidism is that there's very good blood tests that can show us exactly what your thyroid hormone levels are in the blood. So it's relatively easy to keep that at a normal level. If patients are overtreated or undertreated with thyroid hormone replacement, they can develop problems, but that's very preventable.
How early would you start a girl on birth control?
Yeah, so this is a similar question as before, that basically if a girl has gone through puberty and has breasts and is having periods, you can give birth control pills. Certainly if it's too young, like precocious puberty, we would be treating with letrozole, but once they start getting to be at 9, 10, when you would let the puberty progress, it's okay to start birth control pills.
I have it on the opposite. Can I just add to that? Is when do you stop taking it? I mean, how do you know when to stop taking it?
So that's a really hard question. So we know birth control pills have estrogen, which increases your risk of clotting, and as we get older, we all get cardiovascular disease, and are we getting a higher risk of heart attacks as we're getting older? And so it becomes really difficult to know what to do once you start hitting the older age range. And then there's the whole issue of menopause. So menopause on average happens between 51 and 52 in this country. And this whole controversy of whether you should give estrogen after the menopause. And there was a big research study in the 2000s that showed that estrogen did not protect the heart from heart disease. The problem with that study is the women were 64 years old on average, so we don't really know whether the younger women get a benefit from estrogen. And we don't know whether those ovaries are going to keep working and producing some estrogen. So these are really tricky questions. As a gynecologist, I think it makes sense sometimes to switch to something else to protect the lining of the uterus and prevent the bleeding, and switch out of the birth control pills in your 40s if you have other risk factors for heart disease. But this is completely just, thinking it through, not from any evidence.
Is one form of oral birth control more risky than the other?
So birth control pills, the reason we have so many birth control pills is because the patent runs out after 7 years. So they just keep making more so they can make money, okay? So really, you don't need any fancy new birth control pills. The old ones are probably the best anyways.
And if you're pregnant and experiencing more FD pain, is that common? And what would you recommend for pain?
So, Dr. Boyce, I don't remember, but I think we looked at FD pain in our pregnancies, and some people it got worse, some people it got better, and some people it didn't change. So we didn't see a pattern there.
What type of GI issues warrant concern?
Well, the pancreas that we talked about warrants concern. If there is unexplained belly pain, it's real easy to test for pancreatitis with a blood test, so that's easy. If unexplained belly pain, look for that. And this is interesting though too. So as part of this evaluation of the pancreas, our patients also got endoscopies, and what was found, kind of to our surprise, is that on the way down to the pancreas, other abnormalities were seen in the esophagus and the stomach as well, and they were polyps, benign polyps. So polyps are not uncommon, but these were more common than expected. And there was one patient who had in the bottom part of his esophagus, there was actually high-grade dysplasia. So I do think that this is an area we know not enough about, but if you have, and I think again we would use the pancreas as sort of the hook, you evaluate the pancreas, and if there's abnormalities in the pancreas, then that suggests that there could be abnormalities in the rest of the GI tract, and then when they're evaluating the pancreas, they'll do the endoscopy and look at things on the way down. We don't think there's any increased risk for colon cancer that we know of, so but again, that hasn't been well evaluated, but at this time I'd say we don't think there's an increased risk.
Earlier today it was mentioned that fibrous dysplasia slows down as you get older. I started menopause and I'm having symptoms of FD again and regrowth.
Well, I don't know. It's interesting. So the question of regrowth is one that we get a lot, and or regrowth or continued growth or expansion as well. And I would have to say that in patients who feel like their fibrous dysplasia is growing, when we do, or they think their fibrous dysplasia is growing, particularly in the skull, that when we do a repeat CAT scan and actually measure it, there's an unmeasurable difference if there is a difference. So the changes are very, very small. So if there were true regrowth, that is, something increased significantly in size in a measurable way, that would raise concerns for either a cyst in the fibrous dysplasia, which I think was talked about earlier, and will probably be talked about tomorrow as well, which could be picked up by a CT or an MRI, or the concern for bone cancer, as we spoke about, which would also be an important reason to image the bones in that case.
Okay. Thank you so much. That concludes the endocrine portion of today.
So thank you so much. This is not going to be lengthy closing remarks. You guys have been through a lot today, a lot of sitting, a lot of learning. So we're going to wrap up really quickly. There is a patients-only social hour at Not Your Average Joe's between 6:30 and 7:30 tonight. And then dinner for the entire group. If you are admitted to the conference, you are invited. So that's everybody here. Is going to start at 7:30, and that's included in your conference registration, so I hope that you will join us. There is going to be a 2-drink maximum, so we do ask that you all respect that for health, for social niceties, and also for financial budget. So we're nonprofit, so thank you. And one final comment, very important for both in person and our beautiful digital audience who we hope returns and to spend more time with us tomorrow. Tomorrow is daylight savings time. It ends. So the conference will resume at 8 a.m., but the clocks go back. So just keep that in mind. All right. Thank you. All right, so see you at dinner, or you'll see each other at the